Okay, here we go. So, welcome to episode 5 of the eyecare.education podcast. And this week we are doing a myopia control special. And we've got a couple of very special guests coming from all over the globe today. We've got Mark Bullimore from America, and we've got Ian Cameron from Edinburgh. And we've got our usual guest, Peter Charlesworth, back from Edinburgh as well, to chip in and help out. So, I'll introduce the two main guests for you today. We have Ian Cameron, who was he's an IP optom based in Edinburgh. So Ian graduated from UMIST with a first-class honours degree in optometry before he went on to undertake his pre-reg year at the Manchester Royal Eye Hospital. After qualifying, he worked for Eurolens Research and Royal Eye Hospital and taught undergraduate refraction at the University of Manchester before returning to Edinburgh to work in private practice in a specialist contact lens practice, which, among other things, is responsible for the hospital contact lens fitting service in Edinburgh and Lothian. So with diplomas in contact lens practice and independent therapeutic prescribing, Ian lectures widely on all aspects of optometry, from retinal pathology to contact lens materials, and continues to be active in optometric research. So he's managing director of Cameron Optometry Limited, a multi-award winning contact lens and therapeutic specialist optometry practice in Edinburgh that specialises in myopia management. And from America, we have Professor Mark Bullimore, who's an internationally renowned scientist, speaker, and educator based in Boulder, Colorado. So he received his optometry degree and PhD in vision science from Aston University in Birmingham, and he spent most of his career at the Ohio State University and the University of California at Berkeley. And he's now an adjunct professor at the University of Houston. So he's an associate editor of Ophthalmic and Physiological Optics and the former editor of Optometry and Vision Science. So his expertise in myopia and contact lenses, low vision, presbyopia and refractive surgery means he's a consultant for a number of ophthalmic, surgical and pharmaceutical companies. And this work has resulted in the approval of, among others, Paragon CRT, Alcon's iLux and CooperVision's MySight lens. So welcome everyone, hope you're all well.
Thank you.
Hey.
So a few things we want to discuss today. Obviously myopia control is quite a big topic, something that's not really kicked off in a big way over in the UK just yet, but it's looking like it's making a few inroads. So the first thing I wanted to ask you about really was what is the history of myopia control? Where did all this come from? How did it start? And you know, what steps were taken initially to get it up and running?
I defer to Prof. Bullimore for this one. Mark, take it away.
Yeah, I think myopia control has really taken off in the last, well, I mean, it's on the upslope, so it depends where you want to draw your criteria, but it's really been the last 10, 15 years. But certainly there's been a rapid acceleration in the last 5. But people have been using myopia control for decades. I'm often on the podium with somebody who got fit with bifocals as a kid or with rigid contact lenses, which, you know, both of which were believed to slow myopia. But it's really been a combination of factors. First is, you know, we've moved into an evidence-based world, so we hear all the time people talking about evidence-based practice, be it optometry, medicine, whatever. And the proliferation of randomized clinical trials on a number of modalities have really brought evidence to the forefront, so practitioners can sort of point to research and say, hey, this works, this doesn't work. The other thing, of course, is industry is a great driver of the way we practice. So we've seen a proliferation of contact lenses. So we only have one approved in the US, and that's MySight. Everything's covered by the FDA, but you have probably 3 or 4 that are approved or have a CE mark in the United Kingdom and England and Europe. And likewise, there's a lot of activity in spectacle lenses. We can talk about what works and what doesn't work later, but some big guys like Hoyer and Essilor are coming to the front. And as we all know, once big lens gets involved, things move very quickly. And likewise on Atropine, which is perhaps the third wheel. That's currently done through compounding pharmacies, but there are a number of companies. There are actually 3 companies in clinical trials for different formulations, different secret sauce, different methods of application in the United States. And again, we can talk about that in detail. So, I do believe that it's sort of industry and innovation that drives these things. People say all the time, well, I never knew myopia control was a thing. Well, as somebody fairly high up in Alcon sort of paraphrased, you don't have a market until you have a product. So I can point to dry eyes or, can I say erectile dysfunction? These things only became issues or markets important once we had ways to treat them. So myopia is on that same up curve. So anyway, Donald.
There's clearly like a sort of latent desire for it, and that, because when you bring a product and it takes off, there's the evidence that the market was kind of bubbling there or ready to be ignited, but just didn't know or wasn't able to. It was a sort of unmet need, if you like. So even if people couldn't articulate it, there was a desire to have lower prescriptions. I'm -5, not wearing my specs today. It's rubbish being -5. It's even worse being -10. And it's terrible being -15 for loads of different reasons, even if you've got great glasses and contact lenses. It's a right old hassle. And so it's obvious as soon as there's a product that people are going to be excited about it, or certainly a certain portion are going to be excited about it, who have suffered from myopia in the past, and not even just in its kind of more pathological forms, but just in its kind of lifestyle affecting ways. And, I feel that myself. I've got a pair of rimless glasses I tend to wear around the house because I don't really like the look of them, but they're very comfy. And I take them off to fight with the kids or whatever, and then I can't find them. And I'm saying to my wife, like, oh, Becky, where are my glasses? Where are my glasses? And she's laughing at me because she's only -1. It's not fun being -5. For these annoying reasons, even though I don't have any pathology. So there's a huge potential for that, and people were ready for that once it became apparent. People were keen to do something about it. If you can give me a lower number, I want that.
Yeah, like so many things in the healthcare industry, though, and I apologize for calling you by your older brother's name there, Ian. The patients need to be aware of it, and the practitioners need to be aware of it and embrace it. And, we see all the time in our industry that the industry gets frustrated because the profession doesn't embrace and promote. And you can talk about anti-reflection coatings or even contact lenses, things that practitioners should routinely discuss, recommend with their patients, but the uptake is remarkably poor. So you see certainly over here, we have direct-to-consumer advertising for some contact lenses and other products. And that may happen in myopia if the profession doesn't embrace it. Now, I do think people are, as Ian says, hungry for this. I'm doing I've actually already recorded it, but we're broadcasting next week, the first of 2 one-hour segments in the US. And we have 1,800 people registered for that 1-hour CE presentation. Now, part of that is it's free CE, but if this was on a topic that people didn't give a monkeys about, then we'd have 100. But so people are interested, people are hungry for information, and as Ian said, I think this is sort of bubbling, and I think with the right attitudes from proactive practitioners like Ian and his colleagues, things will really begin to take off.
Yeah, definitely. I think from as a topic, myopia control is fascinating because you've got a lot of theory in terms of the actual pathology of the eye, why it's important, and the technical side of how it works. You've also got the materials, the aspects, the contact lens designs, the lens designs that can help, which is also an interesting side of it. But you've also got this kind of almost, I think of the word, you've got this element to it as well, where there is that element of the unknown, and you've got that sort of doubt and that fear that a lot of practitioners have to sort of dip into it. And then you've also got the element whereby could there potentially be legal complications in the future if people aren't offering this now to all of their myopic patients? So there's quite a lot of different sort of elements to the whole myopia control discussion at the moment. So what are your thoughts on potential sort of legal issues coming from this in the future by not having it recommended if the product is already out there?
It's an interesting thing because, for example, when we treat glaucoma, when we prescribe, an anti-inflammatory, we're prescribing now to treat a problem at the moment.
Yeah.
With myopia, we are doing something now that will obviously have some relatively short-term benefits in terms of lower prescriptions and being a better candidate for LASIK. But the real payoff is 50, 60 years from now in terms of risk of eye disease and visual impairment. So that presents a problem for a conservative practitioner who may point to their Hippocratic oath and say, first, I do no harm. Well, if the benefit is way in the future, they may be nervous about doing something that has the potential to cause harm in the short term, whether it's side effects of atropine, whether it's the risks of microbial keratitis associated with some kinds of contact lenses. So that's kind of the thing. So Ian, what do you see, and what, you rub shoulders with a lot of sort of people at the forefront and some laggards. What do you hear?
Yeah, I mean, in fairness, we're all laggards in some areas. On the cut, everything. There's things we're afraid of it. Like every practitioner, there's some things that we lag behind on. I think with that legal argument, I do a fair bit of legal work inside my career in the UK here, and it would be very difficult to make a case to prove that failure to have done myopia management at a young age had a direct impact on some harm that occurred later in life. It'd be very difficult to make that case. And all evidence-based medicine is based around averages. On average, we know that if you take paracetamol, it makes your headache better, but it doesn't treat every headache, and it might not work for you. But on big numbers of people, on average, it works. And the same is sort of true on myopia. On average, we know that this works for most people, but there's outliers all over the place. There's folk for whom you start myopia control and their myopia doesn't change at all. For some, it simply slows, and for some, it has no effect at all. We cannot pinpoint exactly who those people are going to be. And so like Mark's saying, thinking many years ahead as to whether there could be a case proven against you is infinitesimally unlikely, I would say. In fact, we had the same argument, Mark will remember, with silicone hydrogels. For a time, people were sort of saying, wow, these are so fantastic for contact lens practice. If you don't start fitting them now, you're going to get cases against you in the future because you've negligently failed to offer patients the best lenses available. Obviously, firstly, that was a wrong statement. And then secondly, it never transpired anyway that those cases could be made. And I think we're largely in the same territory. We're thinking so far ahead, so far in the future. It's really not a concern at all when I'm practicing myopia management. I'm more concerned with the short-term implications of what I'm doing in terms of costs and risks and things like that. But I'm really not worried that I'm going to get a case brought against me for failing to offer it aggressively at some future point.
Yeah, I mean, I live in the legal center of the world where anybody can sue anyone for anything. And yeah, I think you're right. I think it would be a tough case to make. But, again, you can point to cases in the past in other areas of medicine where a jury has just wanted to do something for those poor women. And in spite of the evidence, they've awarded damages. So, I agree absolutely with you, Ian. But I think we're at the beginning of a shift. And even if people aren't going to be found liable for not doing something, we will see, I think, over the next 10 years, particularly in the US, a change in the standard of care where, I've said in a recent or a forthcoming article, we will no longer prescribe regular single vision spectacles for young myopes. They'll have everything we give them will have some myopia control component in it. That will become the standard of care. And then when we move them into soft lenses, it'll always be some aspect of the lens, be it a dual focus lens or something else, that has a myopia control aspect. I think that's where we will get, but obviously we're not there yet. And obviously in the US, it'll be whether somebody's able or willing to pay, and in the UK, what's done through the NHS will be based on a nice assessment of whether this is appropriate, worthwhile, and that'll, to a certain extent, govern things. But of course, you can practice within the NHS, but then you've probably got a large amount of private pay patients, even on the child side of your practice, and Ian, and there'll always be that.
Yeah, definitely. I think it's a difficult one from the NHS standpoint, isn't it? Because you could argue the case that investing that money into myopia control now would save money further down the line from reducing the risks associated with myopia, pathological myopia in the future. So there is an argument there. But again, cost is always an issue, isn't it, when you're talking about NHS budgets? So it is difficult. As far as I'm aware, you can't. Obviously you can prescribe bifocals for a child for myopia control, but you can't claim that on an NHS voucher because there's no need for a near and a distance prescription to be prescribed. So from a parent's point of view, when it comes to myopia control, it may be seen as them weighing up the cost of it against the potential benefit it's going to have further down the line, isn't it, really, which might be difficult for some parents to sort of understand in that sense.
It's an interesting time, isn't it? So as Mark already said, things are moving fairly quickly. So we've got companies that are launching products into the market, and that's sort of happened over the last 3 or 4, maybe 5 years. But we've also got lots of new research, and a lot of the research has come out in the last 3 or 4 or 5 years. And if you go further back than that, the evidence is there's some evidence pointing to myopia management, but the really strong evidence has come out in the last few years, and I guess over the next few years we'll see even more of that, partly to support the launch of these new products, but also just as the myopia management train gathers speed, and it's amazing how quickly then things change, isn't it? So if you think about, mobile phones, none of us had smartphones pre-2007, and now almost everybody has one. And it's interesting to think, almost nobody does myopia management at the moment. I think it's 1 or 2% of contact lens patients in the UK at the moment, or even 1 or 2% of the children who need treatment. So it's very small, but in 10 years' time, it could be, as Mark says, it could be the standard, and it's at that point then that the NHS will take a look at it and say, is this something that we need to be funding, or is this something that people should fund themselves?
Yeah, the challenge is always going to be, what's the benefit, and the paper that Noel Brennan and I wrote last year really sort of laid out 3 benefits of myopia control. The first, obviously, is better unaided vision, but of course, you also have to realize that low myopes not only see better without their glasses than high myopes, they see better with their glasses and with their contact lenses than high myopes. Secondly, as I said previously, the lower myopes are better candidate for refractive surgery in terms of the quality of the outcomes. They'll have less residual refractive error, less need for enhancements, and of course, the higher myope may not have enough cornea to have a lamella procedure, so they may be forced into an intraoperative intraocular procedure. But the big thing is eye disease and visual impairment, and we've been assembling a lot of very compelling data to suggest that, or to demonstrate that, every diopter of myopia increases your risk of myopic macular degeneration by about 67%. It increases your risk of detachment by 30%. It increases your risk of primary open-angle glaucoma by 20%. Those are big numbers. Now, you can infer from that a lower amount of myopia, and say controlling myopia by a diopter would reduce that risk. But that is going to occur way down the road. People say, oh, we need to wait for those studies. Well, those studies will never be done, because you'd have to randomize kids at a young age and then follow them up at the age of 60, 70. No one's going to do that, let alone fund it. So that'll be the challenge. I do think in the US, it's unlikely to ever be covered by vision insurance or health insurance. And if so, under very restrictive circumstances. But of course, practitioners in some ways like that, because, one of the nice things about dry eye is it tends to be a cash business. That's nicer than having to deal with the modest compensation that you might get from an insurance company. So, you can see 10% of the patients private pay and, make the same revenue than seeing 100% at a much more modest compensation. So I'm not a businessman. I just play one on TV.
Definitely. I mean, do you think, so obviously we mentioned how the emergence of the products has been a big driving factor. Do you think that we'll get to a stage where those products are being advertised directly to patients rather than going through a practitioner to a patient? And will that be the bigger driving factor?
In the US, I mean, we've seen, I think, even AccuView for astigmatism advertised on TV. I don't watch a lot of regular TV, so I may miss these things. Photochromic contact lenses, transitions lenses, a whole bunch of other products. Could this be advertised on TV? Again, it could be targeted to the myopic parents who may be watching a certain thing, but I don't know. I think, when you've got the power of Essilor and Hoya with products on the market, they may be engaged in that kind of thing, but who knows? What do you think, Ian?
I think if you're looking at it from the industry point of view, spending money on television to reach a fairly small segment of the market is massively inefficient. So, if you put a TV advert out there, you're going to get a bunch of old people, you're going to get a bunch of hyperopes, you're going to get a bunch of people who don't have kids, and a bunch of people who are over 20, and then a bunch of kids who don't even understand what you're saying. You're going to get a huge segmentation of the market, which you don't really want. So it doesn't feel like the most efficient way of targeting this group. And it's a very specific section of the population you're trying to reach, which is the parents of myopic children. And we can discuss various ways about how you might do that, but it doesn't feel like television is where you're going to find these people these days. There are
Social
probably more
media?
efficient ways. Yeah, there are more efficient ways of doing it, I think, and that's how we've done it. We haven't put any money into television advertising. So I think there are probably better ways, but it wouldn't be impossible to imagine. The market for kind of direct-to-consumer advertising in the UK of contact lenses is small. It's never been that much on telly. There's an occasional thing from some companies here and there that crosses my plate, but it's never huge. And we don't have a market for it like the US. You go on holiday to the US and it's like drug adverts every 5 seconds. We just don't have that in the UK. And that's because of the nature of the NHS and the insurance market and so on. So.
Yeah, you go to the US, you come home with diseases you never knew existed and products you're never going to be treated with.
Perfect.
Yeah, it's the list of side effects as well, isn't it? Because I saw an advert not long ago when I was but there was beamed over from the US, and I can't remember what it was, but the list of side effects sounded worse than the initial problem, really.
Yeah,
but these people were laughing and joking in the video, and I thought they haven't got any of those side effects whatsoever.
Yeah, no, it's again, because this is all regulated by the FDA. What you can say and what you have to say on a commercial is mandated. So yeah, you're right. You got 10 minutes of happiness, and if you've got this, take this, and then you got 20 seconds of do not take this if you've got A, B, and C, and if you experience this, contact your doctor right away. So.
Yeah, definitely. It's a totally different approach to it, isn't it? But then I suppose in terms of myopia control, it is a case of managing expectations, isn't it? Do you find that one of the biggest obstacles to overcome is that expectation?
Expectation of what
like
expectation?
how effective it's actually going to be.
Yeah. I mean, I guess it's a double-edged sword. It's good and bad that you can see the effect of your intervention, right? So it's not like some interventions like glaucoma drops where you don't derive much benefit when you take them, except when you get your pressure measured. Patients can tell if their prescription is going up or not, and so they can derive some benefit from it, as parents can. They can see whether it's having an effect. So the expectation thing, I don't think that's a massive thing for us. I think the biggest difficulty is the barrier for entry is really high. If you want to get involved in myopia management, you've got to get into full-time contact lens wear from a young age. That's quite a barrier to overcome for parents and for kids and for your practice. And this is why the uptake isn't huge, because you've got to be confident in doing contact lenses with kids, and then talking through the sort of preventative aspect with parents and all these kind of things. And it's a high barrier, and there's a high cost involved financially as well. And I think until the real game changer will be Atropine in the UK, if that's available at low cost, then it will be a big change, because people will suddenly be like, well, the barrier to entry is a relatively cheap drug intervention, although there's some difficulties with giving drugs to kids, and some people are apprehensive about that, of course. But I suspect that'll be the thing that really changes the dynamic, and then you may see growth.
Do you not think, Ian, that
myopia management?
Sorry, Ian, I think you broke up a little bit then. I talked over you. Do you not think that spectacle lenses are going to be the big game changer? Because obviously contact lenses, as you said, you've got to be comfortable fitting kids. Not everybody is comfortable fitting kids. Not all kids want to wear contact lenses. Some parents are uncomfortable with their kids wearing contact lenses. And I'm sure Mark will talk a bit more about the safety of wearing contact lenses versus the risks of myopia, which is the greater risk. But if you can put specs on somebody, you're not administering a drug, you're not putting a medical device in their eye, you're just putting some glasses on. The only barrier then is whether they'll pay for it or not.
Yeah, that's a fair point. And each case as it comes, it depends a wee bit which cohort you're talking about here. Are we talking about people who we think are maybe at risk of becoming short-sighted but aren't yet? Are we going to be fitting them with plano specs with this myopia management element to it? Would parents buy into that as easily as saying, well, take this drug and that'll help prevent them become myopic, or flatten the curve, if you like, for them becoming myopic? But if you're talking about people who are already myopic, then yeah, maybe spec lenses will definitely make a big impact there. So it's probably all these things, isn't it? We need to cover all these different cohorts.
Yeah, I think atropine and spectacles have the potential to be game changers. But again, it depends on availability and pricing and a whole bunch of other things. I often, the myopia control market in the US really started off with Ortho-K, which was always going to be limited because of practitioner and patient or parent perspectives on sleeping in lenses. Soft lenses are growing that considerably, as are Atropine to a certain extent, but it'll be spectacle lenses that will really thrust it into the mainstream. And now the thing with Atropine, of course, is you give somebody a drop, but you've still got to correct their vision. So the next question will be, well, I'm giving them Atropine. Do I give them just a regular spectacle lens, or do I give them the value-added spectacle lens? So I'm doing a combination treatment. Mm-hmm. We don't have any credible data on combination therapies right now. If something slows something by, say, 50% over a year, does that in a second thing slow it by the same 50%? Does it slow by 100%, 75%? We have no data on those kind of things. So there's a whole lot of unknowns, and the evidence base is just going to explode over the coming decade. There's so many questions that need to be answered. Now, Ian, you raised an interesting question in response to Peter. It's like, are we going to get into the prevention business? So if you've got a pair of highly myopic parents and an older sibling who's already myopic, if you've got a 5 or 6 year old who's, let's say, showing some of the risk factors in addition to their parents and their siblings, if they've got very little hyperopic buffer, which we know is a hyperopic buffer is protective, but if they've got less than 3/4 of a diopter at the age of 6, they're at high risk. Might we put them into something? I don't think they're going to wear spectacles, certainly not contact lenses. So is there going to be a pharmaceutical prophylactic approach to a high-risk child? And I think that's another fascinating area of practice. And obviously, atropine could play a big role there, in addition to some behavioral things like getting outside for an hour or two a day, which we know will reduce the risk.
So what does atropine actually do?
So the first studies used sort of high dose atropine, and even back in the 50s, 60s, people were using it, but they were assuming it worked because it knocked out accommodation. Now, a key piece of evidence, actually from one of my UK colleagues, was that atropine actually prevented experimental myopia in chickens. And that was an important observation because the chicken has striated muscle and not smooth muscle. So the atropine, an antimuscarinic, would have no action on the nicotinic receptors in the striated muscle of the chicken. So the hypothesis, which has been borne out to some degree, is that atropine is working maybe on muscarinic receptors in the retina, or has some other disruption of one of the metabolic pathways. Mm-hmm. Now, the other game changer was finding that low-dose atropine seemed to work pretty well as well. And again, you don't want a drug that completely knocks out the patient's accommodation and dilates their pupils to the size of saucers, because that can be debilitating. Mm-hmm. And obviously they would need photochromic multifocals or something in addition to the atropine. But the low dose seemed to have a meaningful effect, and it also seemed to affect accommodation and pupil size to a much greater degree. So you had a good therapeutic benefit without much in the way of adverse events. Now, the great debate at the moment is what's the right concentration. Most people seem to have jumped on the 0.01%, the 100th of a percent dose. But really, when you look at the evidence, it doesn't seem to have much effect on axial elongation, which of course is what we really want to control. And there are a number of studies that suggest we could probably do a whole lot better than we get with 0.01%. So some people are using 0.025%, 0.05% is generally what I advocate. And again, something we've sort of advocated in an article is, you have a control here, you've got two eyes. So if you are worried about side effects, you want to know how much atropine a child can tolerate in terms of it affecting their accommodation, you could just start dosing one eye and see them in a couple of weeks and see how it's going.
Mark, can I chip in here? What's the latest thinking on what on earth is atropine doing if it's not reducing axial length? How on earth are we getting a reduction in myopia? What is it doing, do you think? Or what's the latest thinking there?
I think, there is, even at small doses of atropine, you do get some accommodative artifacts, changes in ciliary tonus that we learned about in optometry school. But you have to really measure the axial elongation to gauge the true effect of any therapy. Because remember, people aren't going to lose vision because of heavier spectacles. They're going to lose it because their retinas are getting stretched and their optic nerve heads are getting compromised. So atropine undoubtedly works at the retinal scleral level in terms of slowing axial elongation. But there does seem to be in a number of papers a disconnect between the change that you get in myopia and the change that you get in the axial elongation. So, as I said, much of the enthusiastic debate is not whether it works or not, it's what is the best concentration. And like any drug, if you've got a dose response effect, you want to probably give the maximum dose that doesn't mess up somebody's quality of life. So, you want to, I would say, particularly in a young, early onset myope who left unchecked is going to end up being a -7, -8, you want to treat aggressively. And if you look across the English Channel to what the Dutch are doing and the young onset myopes, I mean, they're treating with 0.5%. So they're actually using a higher dose and prescribing PALs and photochromics because they know with those early onset myopes, the risk of problems later on in life are huge. Now, do you want to do the same thing for a 11-year-old freshly minted myope who left unchecked might only be a -3, -4? That's, you have the risk benefit conversation. So it's undoubtedly in working at the retinal scleral level. Exactly how, I don't think we fully understand, but it's not working through accommodative mechanisms, but we do have a refractive artifact, I think, regardless of the dose that we use. Is it safe? Well, we're putting a minuscule amount of drug in the eye. And if you look at reports by the American Academy of Ophthalmology, the FDA, if you look at papers where they've been treating amblyopia with 1% atropine, the side effect profile seems to be very good. Now, pretty much every time I'm at a meeting, somebody will say, well, what about the effects of, or the association with anticholinergics and dementia? Well, that's in high dose systemic anticholinergics taken for multiple years in an older population. And if you look at the amount of drug involved, it's almost 1 million times higher than what you would expose a child to with a low concentration of atropine. So yeah, again, some people will be conservative. Some people will be a little bit more laissez-faire, and it's up to us. One of the things that we enjoy as practitioners is we do get to be the doctor, we do get to be the optometrist, we do get to make those decisions and have the conversations with the parents.
And relative risk is an interesting thing, isn't it? Because, we, as you said earlier on in this discussion, cutting myopia by a diopter, which is probably achievable with myopia management, gives you 67%. Well, no, it's a 67% increase every diopter,
yeah,
isn't
40%
it?
decrease.
40% decrease in myopia, and it decreases in risks of other diseases like retinal detachment, glaucoma, cataract, things like that. But how does that compare to the risk now? So you talked a little bit about atropine, but what about contact lenses? So we know that there is a risk inherent in contact lens wear, and I think people who are reluctant to fit children are thinking, well, I don't want to cause a microbial keratitis in a child, because that is something I might get sued for. Do we have any stats on the relative risk of contact lens wear versus the benefit?
Well, Ian's kind of the clinical expert here, but let me just throw a couple of sort of numbers at you. The safest kind of contact lens wear is daily disposable soft lens, okay? Because you've taken the solution, the storage, the case out of the equation. There's no overnight wear, which is another risk factor. So that's very safe. The other thing is the population that seems to be safest are the kids, the 8 to 12-year-olds. The risk of any corneal infiltrative event goes up in teenagers and then goes through the roof in college-age kids. And this has to do with the kids probably following instructions and the parents being involved with the care and handling of the contact lenses. So the risk is higher in overnight orthokeratology, but of course, the kids enjoy the benefit of spectacle-free or contact lens-free vision throughout the day. And that can, if a kid has an active lifestyle and is perhaps getting in and out of the swimming pool twice a day, that may be a much better option. So the risk is there, but overall, compared to the problems later on in life, it's relatively small. So Ian, I mean, you're the contact lens guru. You fit young kids for a variety of reasons, I assume. You've also seen some train wrecks at the hospital. What's your take?
Yeah, I think our experience is, Jeff Walling did a big study on that to show that kids were this great population of contact lens wearers. I think anyone who's been fitting contact lenses for any period of time knows that already. The anecdote was there already that kids just do remarkably well with contact lenses. We just have very, very few nasty problems with contact lenses in kids. And we've been doing it for years, and so have lots of people. And so I think it was good to see some research really backing that up and showing that what we'd all thought was the case was the case. Yeah, I just agree with everything you said. That is absolutely borne out. It's absolutely borne out across the board. And you speak to anybody who fits kids age 8 to 12, and they will say they're a great contact lens wearing population. They turn up for appointments. They do what they're told. They want to please you, so they want to clean their contact lenses, change them when they should do. They want to play by the rules. They want to follow the rules and do well and perform well. That's what kids are like. So they're great. They're the opposite is adults who think they know best, don't want to listen to you, don't want to do what they're told, hate experts of all stripes. Like imagine Donald Trump as a contact lens wearer. Is he going to listen to anything you say? Of course not. A kid would be a better contact lens wearer than the president of the United States.
And yeah. Ian, what about parents then? When you say to parents that your 8-year-old child would be a great candidate for contact lenses, are they surprised? Are they worried about risk? Do they just need a little bit of convincing? How does that work?
It depends largely on their background. If they've been at our practice for a long period of time or proactive contact lens fitting practices, you will have been talking to parents about contact lenses in their kids from the very first time they appear in your practice. So you'll be saying to them, if they're starting to show some signs of refractive error, or they're at risk of having a refractive error because of their parents or other risk factors, then you're going to be saying, hey, we can do glasses, we can do contact lenses. So you're drip feeding that years and years and years before the contact lenses become apparent. So we've been giving out leaflets on myopia control to kids years before they come to then need myopia control. So every time I've got a parent who's myopic, who's got kids, even if the kid's not there, I'm saying, hey, have you ever had your kids' eyes tested? What's the story there? Did you know now there's things we can do to prevent them being as badly short-sighted as you or I? There's nothing you could do when we were kids. And people respond well to that message. And I suppose that's the same message we've been giving people about contact lenses for years. You talk to people about contact lenses for maybe a long time before they decide they want to take up on that. And that works very well with myopia, that you drip feeding that as an approach, as an option for the future. And sometimes you won't need to ever take up that option, and sometimes you will. So I've had very detailed myopia management conversations with parents, only to find their kid didn't go myopic, and it was all a bit of a waste of time. And the kid's now 16, 17, and they're still plano. And I've been saying, they're definitely going to go short-sighted. You're going to need these contact lenses. Get ready. And then nothing happens. And then the opposite as well, having these conversations. And then the kid starts to go short-sighted, and the parents are, yeah, let's do these lenses. That sounds like the right thing. So drip feeding, I think, is the key there, bit by bit for years.
And, one of the things that makes practitioners resistant to do anything is the increased chair time and the return on that investment. And undoubtedly, there are practitioners who are reluctant to discuss contact lenses with any age patient because they say, okay, that's going to take more time and my margins may not be quite what they would be for this approach than this approach. So there's a business, decision there. And certainly for people who practice what I call drive-by optometry or drive-through optometry, where it's about volume and sales in the optical, this is not something they're going to embrace. They'll have to change their mindset and their practice model to say, okay, I'm going to charge more for my time in the chair. I'm going to charge, for a program of myopia management and not just rely on margins on optical products, be them contact lenses, spectacles, or anything else.
And this is why drip feeding is a good move, because you're splitting that conversation over many years. So you're first just teasing a bit about myopia management, saying, hey, there's these contact lenses we can do. The next year they come back, let me tell you a bit more about them, what the research, you're splitting that all up rather than never mentioning it and then needing a 1 hour conversation each time. So
and in examining a young myopic or pre-myopic kid, the exam's not particularly comprehensive, VA's cover test, health check, update on the prescription. I mean, it's something that can be done efficiently and you can use that time. But Ian, I mean, do you have any or all of your staff trained up to discuss these things? Do you have a go-to person in your office that really talks to parents or, is familiar with answering questions?
We've tried to spread it as wide as we possibly can. So I've done a lot of training with the staff about all staff at all levels of the business. They can all talk intelligently about myopia control. So obviously the optoms know a lot about it because they're having the detailed discussions, but every member of staff knows what these lenses are, knows what we're talking about when we're talking about myopia control, knows some of the benefits of it and can talk about it in an intelligent way. So any interaction that a patient has with any member of staff will be positive about myopia management. And if we say, oh yeah, there's things we can do, here's a leaflet, everybody is able to at least have that level of conversation. And that I think is important because all these different touch points that patients we've trained heavily in other ways as well. Like some members of staff have specialised. So Gillian Bruce, one of our optometrists, has really specialised in the science of myopia control. She's off on maternity leave at the moment, so she would probably be better than me here for you. But she keeps really well up to date on all that science and feeds that back to the optometry team, to us. We've got somebody else who really specialises in the ortho-K. But we're all we're all sharing that knowledge and benefiting from each other, although we do have specialities. And we have people who specialise in kids and anxiety and working with kids who've done some qualifications in children's anxiety in order to help them when we're doing the handling of contact lenses and talking through the fears with the parents and the kids about wearing contact lenses. So we've tried to push that as far and wide as possible, delegate it as much as we can across the team. It's one of the benefits of being a big practice. We've got enough team members to do that. If I'm on my own, I have to be all those things. But because I've got 5 optometrists, we can divide the load and people can specialize. And that's a luxury of being a big practice, I guess.
Mm-hmm. Yeah. I can see why you're an award-winning practice with the way you run things.
It's everybody. Like all these things come together, right? We're doing that because everybody's pushing hard in different directions. It's not all coming from my effort and then everybody dragging on my coattails. Quite the opposite.
Mm-hmm. It's fantastic how you've got a whole team that are all passionate about it as well. Because I suppose one of the dangers you could have in a practice where there are multiple practitioners is if you've got 1 or 2 that are quite passionate about it and then the others are quite reluctant or a little bit skeptical, then you're going to have that sort of contrasting information that's going out to patients. So the fact that you've got everyone on board is fantastic, really. I mean, when it comes to myopia control and CET, we've broached the subject at quite a few different discussion workshops and stuff like that. And it's by any means, I'm not a myopia control expert, but I started reading up on it and I found that it was quite an interesting topic to broach with people. And my perspective was, I'm not here to teach you how to be a myopia control practitioner. I'm just sort of planting the seed. So you think, actually, I'm going to look into this a little bit further. But what we found that there's such a low uptake in the UK, and we'd speak to a room full of optoms and DOs, maybe anything from 50 to 100 people, and when we ask who actually takes part in myopia control, you'd be lucky to get 4 or 5 hands go up. But the main reason we get that people don't take it up is because they're waiting for some kind of official guidance from the College of Optometry, from the GOC, and some kind of official, this is what you do. When the prescription's at this level, this is what you prescribe. And until there's that, until it's led by the governing bodies and by the education bodies, people are just a little bit apprehensive. So what sort of made you take that leap, Ian? What sort of gave you the confidence to go and sort of dive into it, as it were?
Well, I mean, it's I suppose it's a personality thing and the culture of your practice and things like that. Like that has always been the culture of our practice, to want to expand our scope of practice, to want to move into new areas. All 5 of my optometrists are independent prescribers. We're all doing specialist contact lens work. We're all excited about myopia control. We want to be doing these things. So it is the culture of the place. And so that culture breeds itself, I guess. And, when there's an opportunity to do something preventative, we're very passionate about that, I think, as clinicians. And you can see why the folk who've engaged in myopia management across the profession are so evangelical about it.
Mm-hmm.
And they just think this is so important because it has this preventative aspect, which we really get excited about. Instead of just treating problems, we can actually prevent problems. And that's really exciting for us as clinicians. And so if you have a practice or a mindset that wants to work like that, then as soon as there are opportunities to practice preventatively, you will seize them. And so all the folk who've taken up myopia management as a big thing in their practice is because they want to be doing that sort of preventative work. They want to be doing the best thing they can for their patients and so on. So, yeah.
Yeah. I mean, one of the things you mentioned, guidance from professional bodies. I mean, I found the College of Optometry sort of white paper or whatever it was on myopia management to be disappointing and conservative. I contrast that with an editorial in the Journal of the American Academy of Ophthalmology, and I'm going to read it now. There was a couple of paragraphs. It said, it's essential for ophthalmologists to work with optometrists who are frontline providers to determine a collaborative framework and referral patterns to prevent myopia progression, educate parents on the risks of myopia, and proactively address associated pathology to best serve the interest of our patients. An epidemic of this proportion will require macroscopic thinking. As such, ophthalmologists will need to reach out and work with optometrists, pediatricians, and even school administrators to develop the best research, reach the broadest population, and achieve the greatest impact. Now, that's an ophthalmology editorial. That's in stark contrast with the sort of, we don't know anything summary from the college. So hopefully things will change as evidence moves forward. And,
yeah, it's interesting the use of the word epidemic as well, because a lot of the studies I've read about and a lot of the information coming out of various sources was in Singapore, and they seem to, I mean, everything I read that came out of Singapore, they used those words epidemic quite a lot, and they were quite worried about the fact that if they don't take action now, if they're not proactive about it now, then there will be significant problems further down the line. So do you think that sort of that mindset has a big sort of impact on how it's practiced in the UK?
Yeah, I mean, when you look at the projections in places like Singapore, Taiwan, where the prevalence is so high, and because of that, the prevalence of high myopia is also high, they're facing a serious public health problem amongst their elderly because of myopic macular degeneration. I mean, even with the prevalence of myopia we saw in the previous century, which is perhaps half what it is now, myopic macular degeneration was in the top 3 of causes of visual impairment. And, the reason being, of course, we can treat cataract, we can manage glaucoma, and nowadays, of course, we have effective therapies for most types, or the wet type of macular degeneration. We don't have therapies for myopic macular degeneration or myopic maculopathy. So they're facing a huge problem over there. So they've got ahead of it. And, myopia management is widespread. I mean, you look at the number of kids in Taiwan who are on Atropine, the number of kids in Hong Kong are on Ortho-K, the number that are managed mainly with Atropine in Singapore. They've been very proactive about it because they do see it as a major public health problem. The American Academy of Ophthalmology is certainly leaning that way, and the optometry bodies are sort of, I think, in step with that. But you do see a little bit of conservatism in the UK, which hopefully, there'll be a little bit of catch up. But I could be a conspiracy theorist and say that seems to be authored by people who have an interest in the status quo when it comes to modes of practice.
Right.
But I'll leave it at that.
Ian, you said that obviously everybody at your practice was keen to get going with myopia control, and I guess having a contact lens background and already specialising in contact lenses helped. But did you come across any kind of pitfalls? Did you start one way and then have to redo it another way, or were there any challenges in implementing that, or is it just something that came naturally?
No, I mean it's been a hard road to get it to where we are now. We've worked hard. It's been what we've wanted to do, and people have been behind it. So I've not found any barriers at all in terms of our staff engagement and the team engagement with the process. I guess we've learned a lot as we've gone on, because the ground underneath us shifts quite quickly. So when we started, we were doing like bi-affinity multifocals with protocols that had been made up by my pal down in Birmingham who sent me them by email, and we were trying to, that was the level of science behind it at that stage. And now, as the products are approved and protocols become more efficient and we get better research coming out from Mark and others, we've refined our process and changed what we do, and we've stopped doing some things and started doing some other things. I'm trying to think of any kind of major problems. Go Mark, you go. Buy me some.
Well, let me. I just actually was going to throw a question at you.
All right.
Have you started measuring axial length in practice, or do you have a way to get those measurements made locally?
No and no. We've up till this point we talk about it like every 6 months. We're like, should we buy an IOL? Are available, and we just deem it probably not necessary at the moment for what we're doing, because we feel that for parents, what they care about is the number of the myopia. The parents don't really care about the axial length, although they should, and although that is the primary marker, they don't actually care. If you said, hey, great, your axial length has only gone up by 0.01 mil, they would go, yeah, but what number am I? And if you're like, yeah, I'm sorry, you're now 5.5, they're going to deem that as a failure. So I think the number still matters more. Now, that's really just an education problem we've got to fix. And you could put back to me that I'm just being lazy and we should train our patients better to understand the numbers. We maybe should. We just haven't quite taken the jump to think that's necessary for what we're doing. We don't think it's impinging our practice at the moment. We keep looking at it. There's better options becoming available at cheaper prices. And so we think maybe we will jump. But we just don't think it's really necessary. We haven't missed it at the moment.
No, I think you're perhaps where you need to be, and particularly, I mean, if you're fitting my sight, there's such a good correlation between axial elongation and increase in myopia that it's a luxury rather than a necessity. I think things will change once we get more data on normal and abnormal eye growth, and already if you read the recent paper by Caroline Claver in OPO, she has their growth curves or normal percentiles for eye length in boys and girls of various ages, and of course that's something that a parent understands. If you say they're at the 80th percentile for height or the 30th percentile for weight, they're used to hearing those numbers.
Yeah.
And I think that's maybe where the field will move in the near future, where we'll be able to not only talk about in the pre-myopic kid whether they are, seemingly at the high end of the curve or the low end of the curve, but once we administer therapy, are we bringing them down from the 90th percentile to the 70th percentile based on our therapy? So, there's a lot of sticker shock when you see the price of some of these top of the line instruments. I mean, I'll speak in dollars, but you're looking at $60, $70, maybe $80,000 for an instrument that's really been designed for a busy cataract surgeon.
Right.
But I know Oculus, Topcon, other instrument makers are looking at sort of, a more myopia focused instrument with a more optometry friendly price. And, I think that will be better. Personally,
it's going to go that way. I think you're right. It's got to move that way. For us, I think all the interventions are in diopters, right? Glasses work in diopters, contact lenses work in diopters. Until we've got an intervention that doesn't work in diopters, diopters are king. So I guess that maybe when atropine comes around, I start thinking, hey, we really need to be doing axial length. But At the moment, we're still in diopter land because that's where everything works.
Yeah.
And you did an audit, didn't you, Ian, on your practice? What did you find?
Yeah, we did that when we hit 50 patients. We thought 50 was a good number to sort of take a look at the outcomes, sort of warts and all. So we didn't varnish it at all and just say, well, this is exactly what happened. We audited every one. And the numbers were basically absolutely as have been published in the industry. So that was quite gratifying that in a general practice, without doing it in like carefully sort of randomized controlled manner, we were just kind of doing the lenses the best we could with the best ideas that we had at the time. The results were the same as everybody else is getting in big research studies. So the message there was, it does actually work in practice. When you take down what these guys like Mark are bringing forward to us in terms of their research, and you actually apply it in an ordinary place in Edinburgh with ordinary people in an ordinary commercial setting, you get those same results. You get some failures, you get some big wins, you get some middle of the road, but on average, you get the same results. So that was good.
Well, that's good diligence on your part, Ian, and doing your own little bit of evidence-based practice. So once again, I applaud you.
Thank you. Yeah.
There's one other question that we need to talk about and we haven't, and it's perhaps more pertinent for atropine than it is for the others. But when do you stop? So you're doing myopia control for kids, and obviously you're going to do it through puberty probably. But when do you think, well, that's it, we've done all the myopia control that we need to, now we can withdraw that treatment? What age is the right age to stop?
Well, the best data we have come from the COMET study in the US, which was started off as a randomized clinical trial of progressives versus single vision lenses, and found a very small effect that was really clinically worthless. But they continued to follow those 400 plus kids into their late teens and early 20s. And the numbers I always remember from their study is that 50% of children are stable at 15, 75% at 18, and 90% at 21. So 50, 75, 90 at 15, 18, 21. But let's turn that on its head a minute. Well, 50% are stable at 15, 50% are still progressing. And even at 18, 75% are stable, 25% are still progressing. So it does vary across children. So again, like Ian is advocating, you got to look at what you're doing. You got to see whether the kid is continuing to progress. And until you see some stabilization, then, why would you change? I would say, in the case of my site, keep the kid in there as long as possible before you move them to a regular daily disposable lens. And the same will occur with spectacles. If they're in an executive bifocal, that may inhibit their dating opportunities, but hopefully there'll be better lenses around that are less cosmetically offensive as we move forward.
We had 3 adult patients in that cohort of 50. 3 of them were adults who just, when we talked to them about myopia, we said, well, look, we don't really know if this works on adults because no one knows if it works on adults, but here's how it works in kids. This is what we think. And their myopia was still progressing. So one was, I'm just looking at the figures here, one was a 42-year-old woman who had continually progressive myopia and was currently minus 12. So we were like, look, and she's, she was always saying, look, is there anything I can do? And I say, well, we've got these contact lenses with kids. There's no reason why we shouldn't try them. So let's give them a punt. Don't know what's happened to her yet, but so people were interested even into adulthood. Mm-hmm. So I certainly wouldn't see any reason why you would stop. And if someone's successfully wearing contact lenses, highly likely they're going to want to continue wearing those contact lenses, even if the myopia management effect is finished. So I would have a very long tail before I would be willing to take somebody out of them. If they're wearing them with no problems and no visual problems, then why would you take them out?
Yeah, because for contact lenses, there's no downside really, is there?
Right. What's the benefit of moving them to regular lenses? Well, maybe some slight cost implication or something, but not huge.
You may have a bit of apprehension from the patient as well in terms of, they might want to be sort of weaned off them in a sense, because they might
Right.
think as soon as I stop wearing these, it's going to shoot up again. So
again, that's questions we don't know. I mean, the MySight clinical trial, they randomized kids for 3 years to MySight dual focus and just a regular soft lens. But at the end of those 3 years, they put everybody was put into MySight for another 3 years. That has just sort of, I think, come to an end. But now they're going to take everybody out of the MySight lenses and put them in a regular soft lens for 1 year. And it's going to be very interesting to see whether there is any sort of post-treatment acceleration and how that varies with age. So it's kind of, I work with Cooper Vision as sort of disclosed at the beginning, but they're really producing some of the best data we have on myopia management, thanks to this long-term clinical trial.
I mean, they've published up to 5 years so far, haven't they?
They presented,
just about to be released.
Yeah, so we'll see how. And I think the 6-year data are going to be very much like the 5-year data. But the next fascinating thing, as I said, is going to be seeing what the washout is. We really don't have any credible data on atropine longer than 2 years. Excuse me. There are some longer term papers out there, which I regard as complete fabrication. But the credible data that we have are only really through 2 years. We have ortho-K patients in publications followed out through 5 or 7 years. We have some idea. But again, we don't have a lot of good data on discontinuation and potential rebound. But hopefully we will in the future. But again, we talked about ethics at the beginning and responsibilities. It's going to be increasingly difficult to conduct randomized clinical trials where we have a control group, because you're exposing kids to the absence of treatment for 2-3 years. Is that really ethical, given the fact we know what the sequelae are? We know we have therapies that work.
Interesting point. Definitely.
That's going to be a light bulb moment, maybe. When we're not allowed to, the ethics say we're not allowed to do the clinical trials anymore, or not allowed to have a control group in clinical trials.
Well, obviously, I mean, that's managed all the time with the FDA and other regulators, where if you're bringing a new drug or a new device or a new lens to market, there's a predicate device or a predicate drug against which you compare, and the criteria, at least in the US, is you have to demonstrate non-inferiority. Mm-hmm. So it's very possible that sometime in the future, the control will be MySight, or the control will be low-dose atropine, or the control will be a spectacle lens that we know what the treatment benefit is based on clinical trials. So we live in interesting times.
We certainly do. Not half. not just because of myopia. Have you got any funny stories for us for myopia control patients? Have there been any weird ones that you've seen?
Well, I've got an anecdote after Ian thinks of something.
Well, there was this one patient who started on the contact lenses and came back after the summer with their dad, who's a doctor, and said that they started taking atropine as well as using the contact lenses. And this had been sourced by their grandmother in India, I think was the story. And they had sourced this atropine and decided that they wanted to give the kid it. And I think the percentage was like 1% or 0.5% or some way high percentage. And they wouldn't be deterred from taking it at that point. They said, no, we think it's fine to do it. And, I'm a doctor, I'm happy to take responsibility for it. And so they were basically sourcing their own atropine and administering it to their own child, which I'm sure breaches many ethical foundations of medicine. But there you have it. And, what can we do? We said, well, we wouldn't recommend that, and here's why, but you make your own decisions. So.
Were they included in your audit? Did it work?
A good question. I can't remember where they are in that. I'll have to look that out. I don't know. But yeah, they'll be in that cohort somewhere, I think.
Yeah,
So,
because you could produce the first paper on combination therapy there.
combination therapy, yeah.
Lenses and
N equals 1. Not ideal.
Yeah, one of the challenges with atropine is that you can obtain 1% atropine in the US and elsewhere in the world, but then you rely on a compound in pharmacy to dilute it. And one of the challenges that we've seen is that when you look at a bottle of atropine, it'll say buffered between 3 and 6 pH. So it's acidic, and that's not because they want it to sting. That's because atropine's much more stable in solution at those pHs. Now, what we've observed informally is the compound in pharmacies are just diluting it with artificial tears or saline or whatever, and really not paying attention to the pH. So some of the uncertainty about low dose or low concentration atropine is, or maybe due to the fact we really don't know what's in the bottle. So that's my atropine anecdote. My other anecdote, and I'm not going to name names here because she'll kill me. One of my frequent co-presenters, her son showed up as a unilateral myope. He'd been ametropic, and then all of a sudden he was diopter and a half myopic in one eye. And she was like, I'm not sure what happened. I said, well, I have a theory. I said, I think he went to church and the preacher said, if you watch things online that are not appropriate, it'll affect your eyesight. And his response was, I think I'll just risk one eye. So anyway.
Well, I think on that note, is that not a great place to end?
I think so. I think there was one more question that I just wanted to ask, just for all those listeners out there that are thinking about dipping their toe into the world of myopia control. What would be your sort of tips in how to get started, and where should they begin?
Ian.
Yeah, so you need to make sure you're confident with what you're saying. So skill yourself up, get the knowledge you need, and there's loads of good resources from that. BCLA, other places will give you tons of stuff on myopia management. So get to know it yourself. And then my first advice is start with the low-hanging fruit, right? Start with the kid who's 10, who already wears contact lenses, whose parents are both -15, right? That is going to be an easy sell. When you say, hey, we could try these lenses, do you want to try them? Both parents are going to bite your hand off to stop their kid ending on -15. And the kid's already wearing contact lenses. So all you're doing is changing one parameter. Don't try and get the -1 myope whose parents are emetropic. That's a hard sell. Start with the easy ones, and then you'll see, oh, actually, that wasn't so bad. Then try someone else, and then build it from there. So pick your most obvious patients who are going to benefit from this and start with them, preferably folks that are already wearing contact lenses. Makes the transition easier.
Excellent. Yeah, and just a shameless plug, although I would derive no benefit from it. Catherine Richdale and I, my colleague at the University of Houston, we've just written a nice, well, I think it's nice, invited review on myopia control, and it should be available online from the college journal, OPO, by the end of the month. It'll be open access, so even if you're not a college member, shame on you, you will be able to access it. And we review the evidence for effectiveness of different therapies, but then we go through a number of things we touched on here. What's normal progression? When should myopia control be implemented? When should it be discontinued? What are the risks? What are the potential benefits? And a little bit of future gazing sort of from 10 years from now, again, things that we've talked about online. So I think anybody listening to this podcast who wants a sort of fairly digestible summary of the state of the art right now and some questions a practitioner might have, I think that'll be a useful start. And as Ian said, there's a lot of good education out there. I would say, it's maybe not common practice, but find a mentor. Find somebody who's already doing it. Find somebody who's willing to, because of a existing personal relationship or be it business or personal, who's willing to sort of talk you through this and be available for 5 minutes here or there. So, what do I do next? So that's my view from my armchair from somebody who doesn't practice.
Yeah, it's a good idea. Really good idea.
Yeah, so you're going to get a lot of calls, Ian.
We'll put Ian's contact details up on the screen at some point, I think.
I'll pass you over to Julian. Yeah, she's the
expert. Yeah, that's good. Yeah.
Yeah, I mean, from my perspective, I think that there's a lot of information out there. So, it's easily obtained. Go and read it, go and take a bit of an interest in it. But I think aside from the clinical methods, obviously the contact lenses, spectacle lenses, there's still a lot of advice that we can give patients, a lot of holistic advice, obviously things like more time outdoors and that kind of stuff. So there's still things that we should be telling our patients, even if we're not actively undertaking myopia control. So there's still a lot out there that we can do, definitely.
And again, the outdoor message is a great one across the board because it has cardiovascular benefits, it has weight loss benefits, and the eyes are just one other thing. So it's an opportunity for optometry to really embrace a broader public health message and be even more a primary healthcare profession with that kind of advice for kids.
Yeah, definitely, 100%. Yeah, so we want to be taken more seriously as a healthcare professional. I think the recent situation with the COVID-19 outbreak was sort of a little bit lower down the list, weren't we, in terms of who the NHS thought we were in terms of being key workers. So anything we can do to raise the profile within the healthcare setting is always going to be a good thing for optics, I think. So yeah, definitely get on board with that. So I think that about wraps it up for today. So thank you to Mark, thank you to Ian and Peter for all taking part. It's been fascinating, to be honest. I think there was a few topics that I was going to ask, but I didn't really need to ask them because we talked about so many different aspects of myopia control that were more interesting than the original questions I had. So it worked out quite well. So thank you all for taking part. I hope you've all enjoyed it.
Yeah, thanks very much.
Thank you.
You're welcome.
Thank you.
Take care. Bye-bye.
See you again. Bye.